Welcome to Health Tech Heroes, where we talk to innovators who are rewriting the DNA of healthcare. Today, we are joined by Jessica Bordeaux, Chief Executive Officer at Raleigh Radiology. Jessica brings a rare blend of radiology operations, IT, and customer success experience, having worked everywhere from the front lines as an X-ray and mammography technologist to enterprise applications, customer success for a startup, and now executive leadership. At Raleigh Radiology, she leads outpatient centers, hospital imaging departments, and teleradiology services, using data, workflows, proven operational frameworks to improve access, quality, and efficiency. Earlier in her career, Jessica became the subject matter expert for radiology applications, building support models, KPIs, and teams that helped clinicians get more out of their tools and time. Today, we will explore her journey, how she is steering a modern radiology organization, and what the future of imaging could look like when technology and operations work together. Jessica, welcome to Health Tech Heroes.
Thank you for having me.
You have gone from X-ray and mammography technologist to CEO. Can you take us back to a defining moment early in a clinical career that you realized you wanted to influence not just individual patients, but how the entire imaging system works? Is there a moment, a aha moment?
There actually is. You have to imagine I excelled pretty quickly from technologist to executive level to eventually CEO, and I get asked this question a lot as of late. And the first time that I thought back about it, it took me a minute to pinpoint, but then once I pinpoint, everything made sense. It was like that aha moment. I was a technologist and knew that helping patients was something that I wanted to do, but I knew that being an X-ray tech forever was not. I was very intrigued by the IT application side of the house. We had a large amount of issues that would happen in IT that would prolong the reporting process. So we would get the patient in timely, we would scan, but something would hold up the process and the patient wouldn't get a report. So I joined an IT team and I helped on the other side of the house implement applications that sped up that process or that fixed the issues. And it was almost eye-opening to see the amount of issues that happen behind the scenes and how easy it is to streamline them if you have the right resources. After getting into that, I realized that the next bottleneck in the chain was the operational workflow. So combining the two worlds and then everything after. So I went back to school pretty quickly to get a master's in business so that I could step into that world as well. So the IT journey really started it, and then everything excelled from there.
Basically, you said with the right resources, did you mean right resources as in people and the plan? Or are you also talking a little bit about the mindset as well? Was there a mindset that was a big part of it?
In radiology, we have a famous question. Do you take someone with a clinical background and teach them IT? Or do you take someone with an IT background and teach them clinical? And as it turns out, you need a little bit of both. And the couple of companies that I had exposure to did not take clinical mindset and plug it into an IT world. And so as operational as IT was, it was missing the context. They didn't understand the reasoning behind why certain modalities operate a way or why radiologists needed one thing if they were reading a brain, but something different if they're reading a breast. So bringing the clinical knowledge together with the IT knowledge is really the resource that was needed.
I see. What you're recommending is it's perhaps a little better if you're in clinical background and then getting into IT, or you think there is a path from being IT and...
I was going to say, I think that there is a delicate balance. I think you need both, but I think that there has to be subject matter experts that represent all sides of the table, whether it's having radiologists on steering committees, whether it's having someone like myself with a clinical background able to speak on that. But of course, I think you still need a foundational knowledge in IT as well. So bringing all the worlds together
is so important. So you just have people with that expertise on the table. And that's what you meant by resource. It's not just the IT resource, but it's the expertise resource as well.
And the knowledge of how to select what's next on the roadmap. So if you have basic resources, but there's a ton of technology out there that can streamline the radiologist or that can help different parts of the workflow, understanding what it is that we need to target next and where those bottlenecks are. So sometimes I think we create these silos between departments, and IT doesn't have a general knowledge of what type of issues or bottlenecks other departments are running up against. So to make sure that you have representation on both sides to help understand what our roadmap should look like and how have a helping hand in deciding what type of applications you should move forward with, or who should be part of those, who's better at the IT side mindset, and who may be a little bit afraid to get their hands dirty in some of the workflows to help clean them up. So having the right resources from correct staff who help with the implementations or piloting, having the right mindset for roadmaps and what it is that you're looking for, and then having someone who can help pull it all together. So I really love focusing on getting all teams together without any miscommunication or silos. One of my focuses is breaking down those barriers.
Percent. And I have been in a situation we used to work with natural language processing and machine learning like 10 years ago, 11 years ago now. As brilliant as engineers are, right? Then what is the output? That's where my clinical background was very useful. So we used to collaborate. We had one of like really productive teams. Looking across your path from frontline imaging roles to enterprise IT and now executive leadership, what were one or two inflection points or hard lessons that most shaped how you lead today?
I would say I worked for an organization that its main business line that I worked for was purchasing radiologists' owned and operated centers. So why that's important in radiology, we have a couple of different ways as most medicine. We either have privately owned, we have some type of joint venture, or we have private equity. And in today's market, private equity is buying out everything, and very rare do you find independent operating radiology facilities. Currently today, I work for an independently owned and operated facility, which is wonderful. But moving from that environment into an environment where the company's mission was to not only partner with and help and potentially buy some of these independently owned and operated practices, but then bring in all of their policies and procedures, their implementation, their software. So it was treated much like a merger and acquisition. And it's very interesting because you can bring a lot of efficiency to these companies. You can bring them reduced cost and applications. You can bring them GPO models where you can get cheaper supplies for medical. But what you also bring is less autonomy. You bring rules and regulations that people aren't used to. You bring a lot of policy that typically is not well received. So it's very interesting coming into an environment where you can bring all these efficiencies, but also bring a lot of cons into the environment. So one of my primary roles was to bridge the gap between the old world and the new world. How do we keep as much autonomy that worked in a smaller private practice setting, but yet bring in some of the larger using that comes along with an enterprise organization? And I think that really helped me because at that point I was speaking at both a corporate and enterprise level, but also for the practice that was trying its best not to change its culture for its people, trying not to change the service offerings for the patient, and trying to have as little impact in the community as possible. They wanted to maintain the reputation that they had built over 75 or 100 years. And that that's a hard thing to do. And I actually got pretty good at it. And there's no better feeling but to both help a practice thrive, come financially solvent, and still help the patient. So I would say that
That's
that would
awesome.
be a major point. And then in my current career here at Raleigh Radiology, one of the biggest pivotal moments for me is the construction of a senior leadership team. We, prior to a few years ago, had radiologists owned and operated fully. So there was no senior leadership team. So bringing in the different department representation and having them really construct business ideas and roadmaps and set those quarterly goals and annual goals and hit them and exceed them. It's a good feeling because it kind of brings me back to that same feeling that I get from the other company. You're able to help the patient truly
Ultimately, yeah.
and run
Ultimately.
a profitable company. So there's something that is to be had whenever you could do both of those things at once.
And ultimately, I think I'm afraid, like in many in healthcare, we are losing that purpose, the end game. Like at the end, why are we even doing it? And hopefully make money doing that, right? But if you don't do the first thing properly, the second thing becomes meaningless somehow. Yeah.
Yeah, I
So you have been described as someone who blends empathy for frontline teams with a very data-driven operational mindset. Was there a specific mentor experience or setback that taught you how to balance people, process, and performance? In a way, these two things, if you look at it from a very high level without getting into the details, looks like there's like two opposing things coming together. Essentially, I think the point of this question is how do you balance that? Like, hey, this is what data says. I don't care what you think. This is what the data says. Go do it, right? And
yeah,
the other
and
part
it
is like, I hear you. How
and
do you balance that?
it's a very delicate balance, and many companies that I've worked for don't know how to balance this, and it's hard. So you have this culture that's created by whatever standard was set, whether it's an older company and it's always the way we've done it around here, or it's a newer business and they set goals that don't align or make sense, or working for a startup company out of Silicon Valley where culture was doing team activities once a week and hopping on a coffee teams in the morning to get to know each other. I've worked for several companies where it was one strict metric enforced environment, or it was lackadaisical. No one really got their work done, but it was very fun.
Okay.
So I think coming in, I've worked for hospitals, I've worked for the VA, I've worked for outpatient, inpatient, and again, we mentioned a couple of others, and every one of them has a different environment. Some of them are, especially, and I think in medical environments, I think you can get it everywhere, but you have clinical versus clerical, you have physician versus non-physician, we just talked about it, IT versus operations. Everything is siloed off and everybody has their own metrics. For me, I think it's very important that you keep the culture, but we have to remember that we come here to work. So as long as we can try to keep a piece of both, I think we're headed in the right direction. I'll use my current company as an example. We had several metrics in place, but they were set based on maybe what was previously done in the past, not to industry standard. Or we had people who had too many job functionalities that you couldn't measure their productivity because maybe they're supposed to enter X amount of orders a day, but their job is also to be the translator for the bilingual language line. And so there's no way to capture what they're doing. What's unfair to them is that they have so many responsibilities that you can't measure it. So one thing that we've done, and we've spent years on doing this, and our employee feedback surveys and different things that we do with HR initiatives prove that we're making a lot of progress, is we give people structure, real structure, not just because you can do it, you should also wear that hat. We've taken away the philosophy that just because someone does a good job means they should have more work.
Oh,
Um,
yeah.
and we try to do a really good job of getting documented policies, procedures, and expectations. And when you do that and you find that Jane Doe's not worried about what her colleague is also doing, and everyone feels like they're all carrying their appropriate amount of burden and have that balance, the metrics come naturally. We
Oh,
also put friendly competitions on them quite often. We reward with pizza parties, gift cards, different things if you go above and beyond. We never have a complaint about an employee meeting their basic needs because once it's set in structure, they really understand it. And big I'm a big proponent that you can't manage what you can't measure. So if we are going off of instinct, it's never going to work efficiently. You're always going to have things that aren't working appropriately. So one of the first things that I did as I came into actually last 3 roles is immediately implement some type of data integration, pull it in so that we have business intelligence and so that we can see what people are doing real time. A week ago, not last Friday, but
mm,
today, what are they doing?
not at the
Uh,
annual review.
yes,
Yeah,
where it's news to them that
very
they've been
typical.
underperforming. You get it, and that's unfortunate, right? That some people
Yeah,
learn
yeah,
at their 6-month or annual review that they haven't been meeting the benchmarks, and
yeah,
maybe they're docked. Maybe they don't get their merit increase that they think they're supposed to because it's news to them
exactly.
that they've not been performing all year.
Yeah, yeah, 100%. Yeah, and one of the things is like you cannot manage what you can't measure, and also you cannot improve what you can't measure. an important part of so you have worked in government, academic medicine, private practice, and health tech startups. Can you share a moment where the change was uncomfortable? Like maybe not so much now, but government is kind of a stable environment, right, for a job at the VA especially. Then you have the academic medicine here in academics, and it is a stable position. But going into a startup environment, it's a risk. And why did you take that risk?
I think because with risk comes a little bit more of problem solving. When you're in some of the larger institutions, you don't have as much room to create change or movement. It's slow and there's a lot of bureaucracy. It gets very political. I think I would describe myself as a very diplomatic person. I try to hear all sides, but it is a much crazier and more exciting environment to be able to come in and make immediate change. So in private practice today, if we make a change, we can implement it tomorrow. If we hate it, we can take it away in 2 weeks. But in some of the academic or government environments or even hospital environments, it's a lot harder. You have an idea, it creates change 8 months from now. If you hate it, you're probably stuck with it.
And it can take sometimes 15 years to change one little guideline. And I have seen those examples. But anyway,
I take the risk because I like the reward that comes with it. It's a lot harder. You maybe don't have as many resources and people lean on you heavily. But for me, that also means that you get to implement changes that are profound and really do have impact. And you get to do so with some pretty extraordinary leaders who are in the proverbial mosh pit with you. We get knocked around a lot. But when we come out on the other side of it, it really is amazing. And I think I live for those moments these days, actually. So I don't know that I'd ever go back. I love living
that's
in this type of environment.
your adaptability, with your capacity to see things and being diplomatic. You have several skill sets, obviously. What made you pick health care in specific? Like I'm talking about like going back to even high school or middle school.
That's actually an interesting one. So the evolution of radiology has been crazy fast over the last several decades. So not long ago, radiology was reading films where radiologists used to put the film up in the light box and turn it on and read it. My father actually worked for Rex, which is a large hospital system here in North Carolina, developing the film. So he would run it through the processor and hang it for the radiologist. And he moved on to several careers after and eventually owned his own construction company, but he could never let go of the fun, the environment, and the stories of radiology. And he had always hoped that one day he'd get back. So when I was thinking through careers, I thought radiology might be a home for me based on the stories that he told. We discussed a little bit earlier. I became a technologist. X-ray is a good career. You see a lot. It comes a little bit repetitive. So you see it, and it's pretty cool for a year or two. You've seen a gunshot, you've seen a trauma, you've seen an accident. But my mindset has never been focused on one thing. So what I also see, aside from the patient care aspect, is, again, how come the order has to come down on a piece of paper and I can't start scanning it until it gets there, but it got lost in transport? Or why the radiologist to see them quick enough. I always get interested in the problems that I want to solve. I'm a problem solver. And I think I also seek out problems. So that might be an issue that one day I'll fix. And so honestly, business then became intriguing. So I got an undergrad in radiology management and knew that I wanted to have a broader focus. So went back and got a master's in business with a focus in healthcare administration and IT. I actually thought that I would belong in IT one day because it's very black and white. But we just discussed I'm a problem solver and I like going out and finding things. When things are black and white, you don't have as many problems. I actually thought about venturing outside of healthcare. It was a momentary, fleeting thought. And as I started interviewing and looking into other roles, I realized I already have so much experience in radiology and the different facets of it that it doesn't make sense to take my skills other places. I think it really does make sense to stay here to uh, essentially help the patient in the end, but also help the practice. We're in an interesting time. We have a radiologist shortage, a technologist shortage, no shortage of patients, and more need than ever. And North Carolina is an interesting state in general. We have limitations on what modalities we can run. So just meaning we have limitations on how many MRIs you can open in one given area, and yet there's a shortage of MRIs for patients. So solving the larger problems, not just company problems, but the problems that are specific to our state or specific to certain populations. Now that's grabbed my attention now.
Great, not asking this, a little bit off topic. What is the logic behind not opening too many MRIs in every region about?
So that came about, we have something called a certificate of need, or CON. And essentially the way that North Carolina works, and this is not all states, it's very specific to us and a limited few, is that you have to get a certificate of need, and it only opens once a year. And it's based on the population, how dense the population is in that county. So not all counties open CONs, and not all of them do it every year. So, for example, in Wake County, which is one of our largest areas here, it's the capital of Raleigh. It's the capital of North Carolina. It is Raleigh and surrounding areas. They only open one a year, and all of us have to fight for it. Our outpatient practice centers, our hospitals, orthopedic if they want an MRI, and we have to give our case. We have to plead how we would use it, how many patients would we help using it, and then a North Carolina agency actually then moves into a decision and gives it to someone. The interesting fact of that is that person then does not have to use their CON. So they can hold on to it. They cannot open an MRI. They may have a different case than you for why you need that MRI, but it then becomes theirs. It's quite an interesting process.
Just stepping back, why did North Carolina even implement a rule like this? What was the reason?
I don't know when the rule was implemented. It had to be in the 80s, and it's not specific to MRI. It happens for hospital beds. It happens for different types. So it happens for PET. It happens for long-term care facilities, and is something that's attached to a lot of operations and what we can do in North Carolina. I believe that the concept was so that we didn't open too many of these things in the area to create a monopoly for patients, to increase or drive up the prices that we could charge. It is very regulated. So I believe that had a lot to do behind it. Thankfully for MRI, CON is going away November of this year in our very dense populated counties, which is fantastic. But the amount of petitioning, the amount of talking to legislation, the amount of politics that goes along with it would blow your mind.
It will probably will. There are a lot of politics going on already in my mind.
So whenever you think of day-to-day operations, a lot of times the thought process is we get an order, we scan a patient, we get reimbursed, we read it, we get reimbursed, and end of story. But unfortunately, there are a lot of federal regulated hoops. There are a lot of state, local legislation. There are a lot of things that we have to do. So part of what we do in our leadership is we are behind a lot of advocacy for getting better access to patients, whether that's patients who don't have access through getting to us because they don't have transportation, whether that's because we don't have enough capacity to serve them because of limitations on CON, or even we join a lot of programs that allow access to underserved or underprivileged patients. So a lot of my time is spent in that world because it really does allow us to open up not only a healthy business, but access to patients.
So for listeners who may not know Raleigh Radiology, how do you describe what the organization does today and core access or quality problems that you're focused on solving for patients, providers, and health system partners?
Raleigh Radiology, like most independently owned radiology companies, we are shareholders. So currently we have 16 own and operate our business. They are radiologists. And then we have, I think right now we're totaling about 75 radiologists in total. And so we both give services to hospitals. So hospitals own their own scanning equipment. They own their technologist, but our radiologists read for their hospital and staff on site. They do the procedures, they do the fluoro, they do everything that a doctor is needed for in radiology. We also own and operate imaging centers. So we own the equipment, we staff the technologists, we scan the patient, and our radiologists are there for the procedures and final interpretations as well. And then lastly, there are a lot of centers that have their own equipment and their own technologists, but doctors are a scarce commodity these days. So they have a lot of APPs. So they have PAs or nurse practitioners that work and can't interpret their own films. So they send us the films for read. So that's what we call teleradiology. So we do on-site services, imaging center services, and teleradiology. And it's a very interesting question of how we help the community or what it is that we get back to them. Because we not only serve very large, densely populated communities on the outskirts of Raleigh, we have a lot of towns that do not have local community hospitals anymore. State funding has been reduced for a lot of these services. We have You see a lot of consolidation where hospitals are buying out other hospital entities and they're reducing services. Interestingly enough, radiology has a radiologist shortage. As of Friday last week, we every year produce about 1,100 radiologists per year. As of last Friday, there were 2,005 job postings listed on the American College of Radiology's job board. So it's a 2-to-1. So there's not enough radiologists to go around for the amount of imaging that's happening. So there are a lot of reasons, one of which people are living through chronic conditions a lot longer than they used to.
Yeah,
So
okay.
they're living longer, and they're living longer with the conditions that once were unfortunately created earlier lifespans. In addition to this, we have a physician shortage. So nurse practitioners and PAs are now ordering more exams than ever. And because they cannot legally interpret in North Carolina, or sometimes they don't have the skill set to do so, we need a radiologist interpretation. The amount of pre-ordered exams in the EDs are going up. So you come in with abdominal pain and you walk into the ED, they're automatically going to order image on you before you ever see the physician. And that's a new practice. Physicians used to order images to confirm something that they were suspicious of. Now they order to eliminate or confirm before seeing the patient. The amount of exams that we call back with positive findings that have yet seen their doctor are incredible.
So you
So
offer
we have
something positive, but they do not have access to the doctor.
So they see the doctor, but what's happening is whenever they go through triage with a charge nurse, or so let's say that you have right lower quadrant pain today. You walk into the ED, you say, hey, I have right lower quadrant pain. It's acute. It just started. As soon as that registration person puts in your pain as the symptom, an order set automatically shows up. So they already order the image. You'll go back to radiology, you'll get the scan, and then by the time you make it to an ED bed to see the physician, they've already seen that you have positive appendicitis or constipation, or maybe it's absolutely negative and there's nothing there. And they move on to the next thing that it could be. So that's different than how medicine was once practiced, where they would come in, a clinician would put physical exam, they would press, they would make sure that you're showing signs that maybe were indicative of appendicitis, and then they would order the images. So a lot different these days. I think also we've moved into a culture where patients are demanding, they have access to Google, ChatGPT. They've diagnosed themselves before they come in, and maybe they're uncomfortable if they don't get the scan before they leave. And by the time they demand it, it ends up getting ordered. And then lastly, COVID. COVID has changed everything. There are a lot of lingering symptoms and signs that are a product of that, and it has increased the amount of scanning that we've had done. And there are various other reasons, but those are the major ones. So we have this increase in volume, and it has actually tripled over the last 2 years alone. So we have an increase in volume, a decrease in radiologists, and since COVID, like many other markets, our radiologists are now retiring earlier than ever. The average age of retirement for radiologists just reduced down to 59. I can't remember the exact statistic and I get it backwards, but I'm pretty sure it's 52% of radiologists are over the age of 57. So if I just told you if they're retiring at 59 and 52% are at the age of 57, that means that half of our radiologists will go into some
Are
sort of
going to
retirement.
go, okay, in like 2 years.
Which means that access to radiologists is going to become more difficult over the next decade.
Just last 2 years, the demand has tripled.
Yes.
Tripled. Okay.
And it's extraordinary. So we are in interesting times. We're in times that we've never seen before. We have more volume than we can handle, and we have not enough radiologists. So many of us are trying to find creative ways to get access to patients so that we don't limit them in where they have to go. Because if we stop seeing patients and drop and reduce down so that each radiologist had the exact perfect amount of volume that they could read each day, we would be taking away their ability to see someone local. They would have to travel. The same concept in hospitals. If we reduced covering these hospitals, they wouldn't be able to find another radiology group to do it. So we've had to come up with pretty creative ways internally to ensure that we are both supplying radiologists and quality reports, but timely. And that's very difficult. So talk about running into a problem that's difficult to solve. It is fun because not only do we come up with these creative solutions, but then we start seeing the product. We see our turnaround times from scan to read reduce. We see quality remaining stable. We come up with industry leading ideas of how to combat this or how to get subsidies, and so much so that we actually talk about these at conferences because we do feel like we're leading the change on it. And those are moments that make me feel good because not only are we helping our patients, but now we're helping others help their patients. And so that becomes a domino effect that makes you sleep good at night.
Talking about sleep good at night, what is that win story that you share with people saying that, we did this? It's because of us. A single patient had an amazing outcome, or the hospital changed the whole infrastructure, and whatever it is. What is that one story that
Yeah.
you share?
I have to tell you that one of my most humbling experiences I've ever done, and I will go back to this one day, is being a mammography technologist. So what a mammography technologist does is they scan the woman's breast for breast cancer, for other things as well, but typically that's the main thing that we're looking for. The reason why this is so humbling is because a large amount of women do have breast cancer, 1 in 8, in fact. Typically, you start scanning around the age of 40, and a woman's supposed to come in every year until they get to the age that if they got a positive finding, they wouldn't do anything about it. So usually that's well into the mid 80s. Unfortunately, patients don't come in timely, whether it's life, whether it's access, whether it's insurance, you name it. They don't always make it in. So some of the community organizations that we partner with are getting women in, whether it's education, getting them to our clinics, you name it. So very often, you typically meet women who have family histories or who have some type of indication that they may be more likely to have breast cancer. But sometimes you meet women who have never had an issue in their life. They've been as healthy as can be. They have no suspicion. They have no reason to worry. And so maybe sometimes they don't come in all the time. For me, being able to be someone who leads this initiative to call the patient to say, you really should come in. I know you don't want to. I know you want to push it off, but come in. One time we did have a patient come in. Not only did we have her come in, but I jokingly threw out, if you have a daughter around 40, why don't you come in with her? You guys can make you guys can make it a nice
Family.
day out, mother-daughter. And both patients were scanned and both patients had positive findings. And the mother had not been in 2 years. The daughter had never gotten her screening as she should have. So after you have a positive finding, you typically come in for a diagnostic and we work it up to see if it needs biopsy. And their cases both did. And in their cases, both positive, and both positive with an aggressive type of cancer, but we found it early. So they were able to go through surgery. They were able to have everything done that they needed to be done. And both are doing very well.
And
So I would
and
have,
it could have been just months. It could have been a different outcome, right?
yes, it depends on how it grows and where it grows. So the mother more worrisome for the daughter, but the daughter also had a positive finding. So I'd have to say that that's probably the most incredible example that I've ever seen. But just being in that world, just seeing the difference that you make in a woman's life, especially whenever they're unsuspecting, or at putting their minds at rest whenever there is nothing there. Maybe they have a family history and every time it comes back negative, and every time they walk out the door thinking, I have another year. So I would have to say that that would be the biggest difference I felt like I've ever made. Whether it's by luck or happenstance, or I don't know why I joked that day, but whatever it was, it brought them both in.
Story, and I'm sure they remember this as profoundly as you do. And one of the things that I typically ask after the wins is a challenge, but I think we did discuss challenges a lot. Unless you have anything specific challenge that you want to bring up.
Legal challenges, environmental challenges, having challenges of culture we talked about. Um, the last challenge that I would say, because I'm specific to privately owned practices, we have a lot of challenges. We have challenges in governance. We have challenges in getting buy-in and some of the ideas that we come up with that we want to spread out to the organization. So I would have to say my only recommendation for anyone who is in a field that has that type of challenge is to go through the correct learning experiences, whether it's certificates or education or some type of offsite, is to learn how to create goals, long-term vision, have people give their input, and then get the buy-in, because those challenges actually become successes if you have the right training and education to know how to pull a group together, keep them away from all those shiny objects that are showing up, and focus on the North Star. It truly makes a difference.
So it was there a lot, and I'm glad that you are at the wheel, as you have always done. You'll get this shit through. So let me jump into the next section. I'm going to combine 2 or 3 questions together just to make sure that we have a comprehensive. The first thing is radiology is changing dramatic. It's like more operational and political, and as you say, rules-wise or guidelines, but also technology-wise, right? Like the AI is going to have a large impact. So considering all this, I'll ask a unique question to you. Would you even if there is a new leader or entrepreneur trying to jump into this field, first question is, do you even advise them to do so? The second question is, if they have decided to jump in, they want to be entrepreneur or leader in this field, what kind of advice would you give them, considering such dramatic changes? What kind of mindset should they bring? What should be non-negotiable when you come into a leadership into such a field where opportunities are abundant, but challenges are equally abundant? What is that leader, or what do you see? What is your advice essentially?
I think radiology is more exciting than it's ever been in the last decade, in my opinion, just because it is so fastly changing. I would recommend for people to get into radiology on the technology side. So you don't have to work in the clinic. You can work on the application side. You can be an analyst. You can be work vendor side to sell the different applications to radiologists and radiology companies alike. Right now, you mentioned your background in large language models. We have a ton going on with that. We have a lot going on with agentic AI. We have a lot going on with different types of automations or bots that help do the job. So I explained to you all of the problems that we're having, bottlenecks that we are having in radiology, and a lot of which is we don't have enough resources. So we're moving at a very fast pace to cover those resources now with um, different language models that help like with interpretations or looking at films or help the radiologist be more speeding and finding things in a workflow, or helping patients call in and do automated scheduling with never having to talk to a human. Different parts of radiology are moving very fast, and because we don't have enough human FTEs to solve for it, we're solving for it in technology. If someone didn't have that type of skill, being a leader in radiology, helping lead that type of transition is also very exciting because you get to move in such a fast-paced environment and you get to learn, and you're ahead of the curve in terms of implementing that change. So I would absolutely recommend someone coming into radiology as long as they like an environment that is physician focused. They like an environment that is rapidly changing, and they can deal with a little bit of that political background that I mentioned, where you can't always create change today, but that it's coming.
As far as the clinical part of radiology, how do you think AI is going to impact the clinical reading of radiology? Is this going to alleviate the lack of FTEs, the radiologist, say in next 2 years, 3 years, 5 years? Or, it's not going to make a dent. What is your opinion?
I do think it will make a dent. I can say that, for example, we just implemented impression generation. So what this does is a radiologist dictates the body of their findings, and it's all the things that they see. And then they do an impression. It's a smaller, condensed version of those findings with just a couple highlights of what's most important. We just implemented the impression generation. And what it does is it takes the last 20,000 reports that were generated by a radiologist, learns their voice, learns them personally, and then starts putting that impression generation at the bottom so they don't have to summarize themselves. That alone, we measure time savings, and it cuts off 15% of the radiologist's workload. In addition to that, though, the radiologist feels less burned out at the end of the day because they're not repeating themselves twice every single report. We have other types of software that we implement. So, for example, there's triaging AI, and what it does is we receive thousands of exams a day. It takes the ones with the most positive findings and puts them at the top of the list so we don't accidentally miss those patients. We can triage them and know that we need to prioritize them. So that helps because it puts everything negative more toward the bottom, everything very positive up at the top. There are companies, then now's the time to get in if you're listening and you haven't considered. There are companies that are now racing against each other to try to solve for how to interpret a film with preliminary findings, putting those findings into a report. And then not only doing that, but making the report sound like the radiologist. And so this doesn't take away the radiologist's job because they're still the person who has to look at image and report and ensure that they match and that it has everything that they would want in it. But we always say it takes the radiologist seconds to interpret the film. It takes them minutes to write their impression of that.
Okay.
So if we can take the seconds of interpretation and turn that into a minute of validation, we can speed up the process.
Okay.
So,
And the writing part, the technology does for you. So that's
absolutely.
minutes becomes like, half.
And
Yeah.
so if we can speed that up, we can speed up how quickly it takes them to get through each interpretation set.
Is actually writing the report. That's a remarkable. I mean, like, looks like you might end up saving more than 15% if you keep at this and if you implement it properly. And this is the last question for you, Jessica. Give you 90 seconds. If there is anything I missed during my questions, or if you want to reiterate something that you think is really important, this is your 90 seconds. Basically, the question is yours, the answer is yours, the stage is yours.
So let's talk about leadership in general. I think that leaders come from diverse backgrounds, and a lot of times they think that they were either meant to start off in leadership or have that goal in mind whenever they started their career. And I think that leaders come from all backgrounds and all trajectories. I don't necessarily think that you had to be born wanting to be a CEO, and I don't necessarily think that your path has to be clean. But I think anyone who has ambition, wants to create change, one who loves to stay up to date on things that are happening in their field, can be that person that leads the change for an organization. I think that there are qualities that are taught, and then there are qualities that people naturally have, inherent to their personality. And anyone, introvert, extrovert, young, older, I think that they can make their way. They just have to have a vision, and they have to have some type of roadmap to get there. But I think anyone can get there. And hopefully they work for a company that sees that as well. You asked about entrepreneurs. I think anyone who has that vision will also do well out on their own. And there are plenty of both healthcare and IT organizations that are exploding right now with needs to solve for staffing shortages, technologist shortage, nursing shortages, radiologist shortages. And there are a lot of people with new mentalities that are out there, and they're bringing forward technology that we would have never thought of. And I just want to encourage people to keep doing that, because I think people get afraid of the FDA, they get afraid of different types of organizations that may be limiting, and they walk away from a very good idea. And the reason why I say that is because we have internal employees that are able to code, that are able to do some pretty amazing things, and they'll do it for a company, but they won't take it to market. And I hate that for them, because I think that there's some extraordinary things that they could do for not even just local to the United States or our company, but for the world. My advice is, if you have an idea, if you have ambition, run with it.
Jessica, with that, I cannot appreciate enough the time that you have spent here with me. It was very educational.